and YouTube now. Ten seconds before we start. Ready to start now? We're ready to start now, Aaliya.
Yeah, my camera's. Bismillah. I'd like to welcome you to this webinar on NHS records and GP data privacy, hosted by the British Islamic Medical Association. My name is Dr. Aaliya Goyal, and I'm a GP and your chair for today. I'd like to thank the BEMA webinar team for organising this event with Dr. Salman Moqar and Dr. Arshad Latif. So I'd like to start by introducing the topic. NHS patient GP records are the most detailed and sensitive records that exist. Stretching from the cradle to the grave, they are a timeline of an individual's physical and mental health. Following an Act of Parliament that became law in May 2021, NHS Digital announced that the data may be shared from GP medical records of any living patient registered at a GP practice in England on a specified date. Initially, the 1st of July was given as a date for the start of the data extraction, but following concerns from individuals and organisations, including the British Medical Association and the Royal College of General Practitioners, this date has now been pushed back. The new system, known as Gp Dpr, which stands for General Practice Data for Planning and Research, will replace the previous system called the General Practice Extraction Service. NHS Digital, the Health and Social Care Systems Information and Technology Partner, will be able to take the following from GP records: data about diagnoses, symptoms, observations, test results, medications, allergies, immunisations, referrals, recalls and appointments, including information about physical, mental and sexual health. This will also include data on staff who have treated patients and data on sex, ethnicity and sexual orientation, as well as other sensitive data. Patients' data will now start to be extracted from GP systems across England from the 1st of September 2021, giving individuals until the 25th of August to opt out. We have some excellent speakers for you today, and we are looking forward to a useful and informative session, inshallah. After the speakers have finished, we will be opening the floor to questions, so please feel free to send your questions via the Q&A box. We would also value your feedback, and we'll be sharing a feedback form for you to complete to help us to plan future webinars. The link for this will be shared in the chat and can also be accessed using the QR code on the poster. So I'd like to start by introducing our first speaker. Dr. Osman Bhatti is a GP in East London with a specialist interest in IT. He is the CCIO, that's the Chief Clinical Information Officer for North East London Clinical Commissioning Group. He has supported numerous digital projects and enables solutions that support patient care and assist in streamlining processes within clinical practice. He is also a GP Training Programme Director and supports education and learning initiatives. Thank you, Dr. Bhatti, and it's over to you.
Thank you very much, and thanks for having me. So what I'm going to do, I'm going to just share some slides and just go over a presentation of my perspective from a GP's perspective on the GP Dpr. So I'll just share that screen now, and you should be able to see that here. So essentially, just as Aaliya introduced, I'm a GP in North East London, and I'm coming at it from that angle, and I'm also the IT lead CCIO for my local area. Now, the background to all of this is that actually we as GPs have historically held data. Patients have given us the data to help with their health, and GPs have been recording this into the GP clinical record. Now, patients give their data to patients give their data to healthcare professionals, GPs, hospital doctors, in a secure, confidential way, and they expect that actually this is not revealed to other people, and they give it in confidence. So my underpinning statement here, which is the thread that I want you to think about, is that trust is paramount, and that's what I'm really concerned about here. And that's because anything that breaks the trust will ultimately be detrimental to the patient and to the doctor, really. So that's the basis. And if you have a look at how we use data, we generally use it for direct care. Direct care is where the GP and the hospital both record information about the patient, and that's shared. And the data just flows, and that's not the issue here. We know that when somebody goes to their GP and they have a referral to the hospital, the data gets transferred, and likewise, when they're seen in hospital, the data gets flowed back to the GP practice, and that's direct care, and that's not the issue here. The issue is around planning and research. So when we do planning and when we do research, we know that's a good thing, and actually we're involved in this locally, we do a lot of this, but it's how we do this and how we uphold the security and confidentiality to maintain that trust, and that's what's important. So the NHS want to do something different. So the NHS have a government organisation called NHS Digital, which is accountable to the Health Secretary. So that's the accountability. And they want to take the coded data from GP records, which is confidential, okay? And they want to take this through a legal direction. And they've done this essentially without properly informing patients or GP practices. And they've openly said, actually, we now want to be able to combine that data with other data that we hold within government organizations, and then build what we call a data warehouse. So a data warehouse will be built with all of this information in, and they want to use this for research and planning and other secondary uses. Now, this became a legal direction on the 12th of May, and the initial plan was for it to flow on the 1st of July. And as Aaliya said, this has been pushed back to the 1st of September. Now, if we just look at that in itself, that initially was a 6-week period for data to flow, and that's what really got people concerned. So you had a legal direction and a date of activation within 6 weeks, and there was no publicity. It just happened, and the campaign therefore started actually locally with us, and also the RTGP, BMA got involved, and the date was pushed back. So that's where we are currently. Now, what is ultimately the issue? The issue is that NHS Digital are going to be taking data from the GP record, putting it into their own database, and then sharing it with others for a purpose. And I think the issue here is that we don't know clearly how that data is going to be used and for what purpose, because what NHS Digital haven't done is published what we call a impact assessment. An impact assessment, we call it a DPIA, a data protection impact assessment, is done whenever we're using data or sharing data, so that it's clear to anybody who wants to know how is the data being used and what purpose, and therefore there can be clear transparency alongside it. And I think that's the issue that we've got at the moment. There's a slight other thing that I just want to talk about as well, and that's anonymization. Most data that we hold, and we use this for direct care, is because we identify patients. We identify patients and we say, Joe Bloggs has this condition and that condition, and we can help them with their care. When we talk about sharing data, we need to be careful when we use identifiable data. And normally identifiable data we use with the patient's consent. So for example, if I'm going into a trial and I want to use my data, I'll have my consent given, and that will allow people to use my data because I know about it. I've offered it freely. The flip side of that is anonymization, and anonymization is where you cannot identify the patient. And we use this, for example, when we're counting the number of patients with high blood pressure in the practice. So we anonymize the patient, so you don't know who it is. All you know is that there are 250 people with high blood pressure in this practice, and that's anonymization. So you don't know the individual, you just know something about that person, but not in an identifiable way. NHS Digital wants to do something in between, and that's called pseudonymization. Pseudonymization is where the data is taken in an identifiable way, but a key is put on, a pseudonym, which effectively does not identify the patient, but NHS Digital can, if they wish, unlock that and be able to share that identifiably to link it to other data sets. And that's primarily what they want to do. Not really a specific issue generally. I think it's done quite a lot, but the question again is for what purpose and why is it being done? And if we go back to the examples that we currently have with things like Palantir, Cambridge Analytica, even Google DeepMind, that there are lots of ways that data has been shared, and we need to be careful about that. And I think that's the other issue that we really need to be understanding. So what alternatives do we have? And I think one of the things that we really are thinking about is actually we don't want to be blockers, we want to be able to do this properly. And there is a proper way of doing this, and this is by using a trusted research environment, which does exist, but isn't being used. And I think this is something we need to think about really. So a trusted research environment, we've got an example of one, it's called Open Safely. You might have heard it in the news recently. It's been doing some really, really great data reviews. And what that does is basically where you've got the data, and with the knowledge of the practice, it goes into this trusted research environment. It's open and transparent. We know exactly how the data is going to be used. Generally speaking, it's anonymized because all the linking and identification is done at source or within a trusted environment, and it's clear for what purpose this is being done. And then NHS Digital can potentially then take that and use that and share that because there's a consistent approach, and there's a way that we can essentially identify for what purpose the data is being used. And I think that's a key. These things exist, and we need to think about using that in this case. And that's why there's been a lot of talk about opting out. So because the current situation is just as this slide demonstrates, where NHS Digital are going to take the record and hand it over to other organizations or to use the data for planning and research and to do other things, we have to really think about what the impact is going to be. And because we don't know what that impact is going to be, then patients should have the right to opt out. And this again has not really been publicized. And one of the key things that we're really looking for and asking for is actually how can we better inform patients to say, actually, this is what we're doing, this is how we're doing it, and these are the options for you to opt out if you feel that this is not something you want to do with your data. And remember, actually, the data that is being taken is everything, virtually everything from your record over the last 10 years. So that 10 years of data, and that will be regularly extracted from your GP record and used for various purposes. Now, there's two types of opt-outs, and I think it's worth just labeling this because there is quite a lot of confusion around opt-outs. As you can see, that the data leaves the GP practice, goes to NHS Digital, and then NHS Digital use that for other purposes. Now, the first type of opt-out is called a type 1 opt-out. And a type 1 opt-out prevents the data leaving the GP practice in the first place. And that's done by completing a form, giving it to your GP practice, and the GP practice will then apply a code to the GP record, and that code will prevent that transfer of information. It's quite a laborious thing for the GP practice. It's been in existence for quite a long time. There was a similar scheme about 7 years ago called care.data, which you may have remembered, which was a big data extraction, not as big as this. I hasten to add, this is a lot more, but that data extraction, actually, there was good publicity about it. Every household was informed about it. There was lots of information to GP practices, and there was a clear way to opt out. that opt-out hasn't really been publicised here. So we don't know what's happening. There's been no clear way of opting out. Now, that opt-out can be done by completing a form and handing that to your GP practice, and that will prevent the data going in to NHS Digital in the first place. And that's something that anybody can do. The other way of opting out is called a national data opt-out. Now, the national data opt-out is where the data is already with NHS Digital, so it's already left the GP record, but NHS Digital can say, actually, this patient's got a national opt-out, and therefore we won't use this data for forwarding on to for other uses, which is great in theory. But if you actually look at the practical application of this, 80% of the time, NHS Digital have overridden that national data opt-out, and they've got a clause to say actually they can unlock the national data opt-out objection if they feel necessary, and under legal direction they can do that. So actually the national data opt-out is there for patients to do, but if you look at how it's been used, it hasn't really been honoured in the way that we would have expected with confidential medical records.
Okay, 1 minute left.
So to summarise, thank you, that's where we come back to trust. And I think we really need to ensure that trust is maintained between doctor and their patient, and to record this data securely. I'm all up for using data. We use it all the time for direct care. We need to really think about how we use that securely, and anything that undermines that is going to affect not only patient care, but also research and planning. So we need a trusted system that's not sneaked in over 6 weeks, which is now 14 weeks. And to date, we're unsure about that data protection impact assessment from NHS Digital, and that's where my concern currently lies. Thank you.
Thank you so much for that, Dr. Bhatti. That was really, really informative. We're already getting quite a few questions in, but what I'll do is I'll save them for the panel session at the end. But thank you for your thoughts. I'd like to move to our next speaker now. So I'm moving to Professor Azeem Majeed, who is a Professor of Primary Care and Public Health and has been the head of the Department of Primary Care and Public Health at Imperial College London since 2004. His research interests include health policy and the organisation and delivery of healthcare, the use of information for policy, planning and research, and developing innovative methodologies for patient care and public health research using clinical and administrative databases. Professor Majeed is also a general practitioner and has acted as an international advisor for the World Health Organization on areas such as health systems, universal coverage, and primary care. Thank you for joining us today, Professor Majeed. Please continue.
Thank you very much, Dr. Goyal. It's a great pleasure to be here today to speak about Gp Dpr. So I'll just share my screen first. Great. So thanks very much for inviting me to speak here today. So I'll speak about why we need the General Practice Data for Planning and Research program, Gp Dpr. Obviously, there are some caveats about that, but hopefully I'll give reasons why we need this program with suitable protections going forwards. So as Dr. Goyal mentioned, I'm Professor of Primary Care and Public Health at Imperial College London, and also head of departments, and I'm also a GP and public health specialist, and I do work in the NHS in all those different roles, as well as my academic work. So before starting, a few declarations about myself. So I've received funding for research using data from NHS medical records from a range of funders, including the NHS, the NHR, the Medical Research Council, and the Wellcome Trust. And I have been using this data for research for over 25 years. So I do have a lot of experience using the data for research in a confidential manner and using that data to support public health and healthcare delivery in the UK. I've also in the past been asked to write reports on this data for various bodies, including the Department of Health in 2002 and the Association of Public Health Observatories in 2005. So as well as my published papers in journals, I've also written a number of reports on these data for public bodies as well. So I do have a lot of expertise in this area. I also worked at the ONS for 7 years, from 97 to 2004. As a medical advisor, and so also in that role gained experience in using other medical data such as mortality records and other data collected by government for research and public health planning. So I do have a lot of experience in this area, and I also, as I mentioned, carry on working in NHS general practice and also in NHS public health, in addition to my role as a professor of primary care and public health at Imperial College, London. The NHS in England, like other health systems globally, does face major challenges. The population in the UK is ageing. We need greater support for frail older patients. The prevalence of many conditions is increasing, for example, type 2 diabetes and other medical problems. We need a bigger focus on prevention and healthy living to try to overcome some of these issues. We also know that quality of care varies greatly between GP practices, between hospital trusts, between areas. And so these issues also need addressing as well, because people clearly want to get good quality healthcare, no matter where they live or whatever GP practice they have to happen to be registered with. We also know there are great pressures on government spending and a lot of pressure to get better value for money from the NHS in terms of what it spends its money on. And also for the last 15 or 16 months, in the midst of a pandemic as well, which has also had a lot of impact on the NHS and has meant we needed our data to use to support public health planning, surveillance and research on COVID-19. So it's quite clear the NHS does face many challenges, and going forwards, we do need to have data to address those challenges, whether it's for NHS planning, public health surveillance, or for biomedical health services research. And this is just one example of what problems we face in the future. This shows the predicted rise in the number of people in England with various long-term health problems between 2010 and 2040. That should be sorry, not 2010, 40. And so, as you can see, most problems are going to increase quite substantially. So problems like arthritis, cancer, dementia, diabetes, stroke, etc. Those are also going to increase substantially over this period. And this will impose further strain on our health service and reinforces the need for better healthcare, both from both prevention and treatment, and also managing people with multimorbidity in the long term. So over the last 30 years, we've seen a shift away in the NHS from using paper records to using records that are computerized, and we now full use of computers in all GP practices in England, and that's been the case now for about 20 years or so. And so through the work of our clinical colleagues, whether they're doctors, nurses, or other professionals, we do now collect a lot of data on the patients, as Dr. Bhatti mentioned in his talk. And that's added to by data from laboratories, for example, lab results, or the data added by primary care staff, such as data on hospital activity. And this provides a unique resource for research and planning and public health surveillance. And we've seen this value of this data over the past year or so during the COVID-19 pandemic, and we've really used data a lot to support our response to COVID-19. These data are population based, as was mentioned by Dr. Bhatti. Most contacts with the health service take place in primary care, and so the records we have information on most aspects of care, whether that's mobility, measures like blood pressure and height and weight, laboratory test results, treatments, prescribing, so most drugs are prescribed by GPs, and also information on outcomes and use of health services as well. So we've got a very rich data set that is very valuable for many people who want to use this for additional purposes other than direct clinical care. The data, they do have some weaknesses. So in the past, it's often come from volunteer practices, which may not be typical of the average general practice. We know the quality of data varies quite widely, as does how well the data is completed. There's also lack of data on things like ethnicity, although that's improving now. And also in the past, we've had multiple clinical systems used to record data, which are often not well linked hospital systems. And data has been hard to access in the past and quite expensive. And hopefully going forwards, Gp Dpr can help to address some of these weaknesses, so improve quality of data, improve data linkage, and improve the value of data to the NHS and other bodies. So the data is quite comprehensive. It includes data on things like demographics, so date of birth, ethnicity, clinical diagnoses, so things like diabetes, pneumonia, sore throats, abdominal pain, and it's coded using either read codes or a newer system called SNOMED in the UK. We've got data on measurements, so things like blood pressure, height, weight, body mass index, information on preventive care, so screening, smoking status, vaccinations, health checks. As I mentioned, most drugs are prescribed by GPs, so that data is also in the record as well, and that's added to by laboratory data, so tests that GPs request, for example, blood cholesterol, other lipids, glucose, renal function, etc. Those are added to the record as well, which increases its value. And over the past year also, we've added data on COVID-19 testing and vaccination as well to increase the use of the value of data to the NHS. And in addition, we've got other records we could link to these data. So this includes data on hospital episode statistics, data from the ONS on mortality, so cause of death data, data from our cancer surveillance systems on cancer incidence and treatment patterns, data from audits, for example, in diabetes, additional lab data from tests organised by hospital specialists, and imaging and data on things like x-rays and scans, so from images that people have taken as well. So we can really expand the value of this data through linkage if that's done in an appropriate way that's confidential and doesn't breach any issues of trust. And these data have a wide range of purposes. Clearly the main purpose of the data is to provide medical care to patients, and that's always going to be its primary function. But beyond that, we've got additional purposes the data can be used for. So planning health services, it's very important to know the prevalence of disease, how it varies, across the country, by age, by sex, by ethnicity. We need to measure clinical performance, so know how well different providers are performing, whether those providers are GP practices or hospitals or mental health trusts. We have to measure health service usage. That allows us to measure things like waiting times, waiting lists, and plan healthcare appropriately. We need information on public health surveillance, so we need to know about disease prevalence, about risk factors like smoking, alcohol use, obesity, and others vary across the country and in different patient groups. We need to monitor inequalities by age, by sex, by ethnicity, by area, and look at how well the NHS is working to address those inequalities. And finally, we need data for research as well, whether it's research on health services, epidemiology, or clinical trials. And the data are very valuable for these additional purposes also. I'll just give a few examples of research which I've done using these data sets. The first one is just around looking at cardiovascular risk across England, how it varies for men and women in the country. So you can see there are quite stark differences across the country in the prevalence of cardiovascular risk, with some low areas in the south of England and much higher rates in the north of England, for example. And these data are very helpful in terms of planning healthcare, whether that's prevention, primary care management, or specialist services like cardiology services, cardiac surgery, etc. So those data are very valuable when they're used appropriately and carefully and sensitively. The second example is from recent research done on looking at care of people with diabetes, in this case type 2 diabetes. So we looked at a range of outcomes, and this just shows one outcome. We also looked at things like amputations, retinopathy, and death as well. And it just shows that the people who receive better quality of care do have better outcomes. So if you have your blood pressure controlled, your cholesterol controlled, your glucose levels controlled, then you have better outcomes in terms of your diabetes. And that's very important to know because it helps us to plan services, fund GPs to provide care they need to improve outcomes for people with diabetes. So again, another example of why data are valuable going forwards. Clearly, there are concerns about the Gp Dpr program. It wasn't well publicised, as Dr. Bhatti has mentioned. Opt-out is not straightforward. It's paper-based. So you're print off a form, send it to a GP, who then enters the data onto your system, and so you have a code which then opts you out of the system. There are concerns about confidentiality and the use of the data. So I think people probably happy if it's used by the NHS, but if used by other government departments or by industry, that will raise concerns amongst the public. If people opt out in large numbers, that would reduce the value of the data to the NHS, because we would then have a data set that was not providing complete coverage of the population, and so would be less useful in terms of planning and research going forwards. And the other problem that's rising now is that GPs are getting many requests to opt out from patients, and that's adding to their workload. They've also been asked to carry out impact assessments on the use of the data as well for Gp Dpr. And clearly, when the NHS is very busy at the moment, it's not good to have NHS staff working on these kind of things. It would be better if it's been planned properly and these issues have been dealt with in advance rather than being dealt with now at a very busy time for the NHS.
Thank you. 1 minute left.
Thank you very much. So a few final thoughts. So in my view, Gp Dpr is essential for the NHS in England and also for public health bodies as well, and for universities and other research organisations. It's important also how we use data to support our industry as well, clearly with protections from, about things like confidentiality. And we need to build public trust in the programme and in confidentiality going forwards. And in my view, it needs to be overseen by an independent committee which can, really review requests and make sure those requests are appropriate for the use of the data. But without good data, the NHS is flying blind in terms of planning and research. So really, we need data, and we need some way of making sure data is available for the NHS and for research as well going forwards. Thank you very much.
Thank you, Professor Majeed. It's certainly given us a lot to think about. Again, we're getting lots of questions, which we will put to the panel at the end of the session after they've all finished speaking. So please continue to send your questions in. The feedback form link has also been put into the chat. So I'd now like to introduce our third speaker. So Monika Sobiecki is a specialist data protection, cybersecurity and digital rights barrier, and she's a partner at a highly successful multidisciplinary London law firm with a reputation for being at the cutting edge of legal developments. She has a wealth of experience in all aspects of data and information law. Ms. Sobiecki has worked for individuals, public and private sector organisations, advising government bodies, research institutions, charities, universities and global companies. She is passionate about the protection of digital rights and building better tech which embeds privacy and ethics by design. It's a pleasure to meet you this morning and we'd love to hear from you. Thank you.
Thank you very much, and thank you for the opportunity to speak today. I'll just share my slides. Hopefully everybody can see that now. Fantastic. Sorry, just move this across. So I'm here to talk about some of the legal issues with the Gp Dpr proposal, and actually to echo some of the comments that Dr. Bhatti and Professor Majeed made. I do see the potential value of sharing health data for research with suitable safeguards. However, I also come at it from the angle that in order to have a system which has public legitimacy and that people are actually happy to give their data to, this must be based on trust. And to build trust, you have to think about people's privacy. And it's not just about filling in bureaucratic paperwork as required by the GDPR. Of course, it's about respecting the rights of the individuals whose data is going to become part of this database, as it so happens, irreversibly, because even if you submit an opt-out after the 1st of September, your data going forward won't be collected, but anything that's already been collected will stay on that database. So we might have a bit of a sense of deja vu because the government has had some practice in launching similar schemes, and so you'd hope that they do a bit better this time. As Dr. Bhatti mentioned, this is care.data. You're likely to remember this one, a proposal in 2013. Which was criticised at the time for lack of patient awareness. And so leaflets, which looked like this, were sent to households across the nation, but they didn't contain any opt-out forms. And again, public criticism of this meant that eventually the proposal was shelved. So clearly public awareness of the scheme was an important factor there. And then in 2016, we heard about the tie-up between the Royal Free Hospital Trust and DeepMind, now Google DeepMind. Initially, DeepMind were given access to 1.6 million patient records for testing an app. The ICO investigated, as did the National Data Guardian. And the ICO found, again, that there was a lack of patient awareness as to what was happening with their data. The ICO also criticised the safeguards in the contract and the data security measures for that scheme. And so the Royal Free had to give undertakings that they'd set up an independent audit committee and also commit to better transparency for patients. So you can see that there are some themes that have come up in the past. And it's not the first time that public authorities in the UK have had to grapple with the legal ramifications of a major data sharing scheme. As we'll see, though, these lessons have not really been learned. And you might, if you're a GP and you're listening to this talk, you might be thinking, well, why, how exactly does this concern me? Well, this diagram is from the directions published by the Secretary of State, and for the uninitiated, and I'm sure that's none of you, a data controller is an entity or an individual, in this case, GPs or data controllers, who is responsible for accountability under the GDPR and also is liable for any breaches under the GDPR. That means that the data controller in this case will be responsible for explaining to patients exactly what's going to happen to their data, and is also liable if it all goes wrong and the patients are unhappy and there's a breach of GDPR. The scheme is structured so that GPs are responsible as data controllers for the transfer. So that means that responsible for all the GDPR measures, responsible for accountability. So given that GPs have so much on their plate, you'd hope that NHS Digital would have done the hard work for you, would have helped you out. So if we look at what the ingredients of a data sharing scheme, so we can mark NHS Digital's homework a bit now. What sort of ingredients do we actually need for a data sharing scheme in the public health context? Well, we don't have time today to go through all of them, but I'd suggest that there's a couple on the slide. Firstly, compliance with the data protection principles enshrined in GDPR and the UK Data Protection Act. So these are principles like lawfulness, fairness, and transparency. You need to have a lawful basis for processing the data. You need to make sure the processing is fair and what patients would reasonably expect. You need to make sure that your transparency obligations have been met, that patients are fully informed. Data minimization is an interesting one. A scheme which hoovers up an entire GP record, does that really comply with a principle that data should be collected, should be adequate and limited to the purposes for which it's needed? Perhaps actually a proposal like the Open Safely proposal might be a bit better for data minimization. Adequate safeguards. So in this case, it's not just technical measures to protect security of the data, but in order for the scheme to be proportionate, it needs to ensure that it has full and proper ability for individuals to opt out if they wish. Proper consultation period, so an adequate period for patients and GPs to consider proposals. A data protection impact assessment. So interestingly, the ICO publishes a mandatory list of factors which require a data protection impact assessment. And this is not just a paper exercise. This is a full review of what you're doing with data and the safeguards you're going to implement. And it should ideally be openly published and published before the scheme starts. Transparency, so full and proper privacy notices, and also compliance with the Caldecott principles. So principle 6, for example, of the Caldecott principles is to comply with the law. We've talked about privacy law. Principle 8 is to inform patients about what's going to happen with their data. So what has actually happened so far with GP Dpr? What ingredients do we actually have so far? Well, the consultation, as we know, the government took a sort of decide, announce, and then defend approach rather than a consultation approach at first. That consultation period has now been extended from the 23rd of June to the 1st of September following a legal challenge. Question, is this going to be enough time still? It's a major scheme. Secondly, transparency. I mentioned that it's actually GPs who are responsible for explaining to patients what's going to happen with their data being transferred. There is a template privacy notice, but it seems to be missing some information. Are you happy as GPs that it contains everything you need in order to inform patients? Have your patients actually been informed that this is happening? Thirdly, adequate safeguards. As Dr. Bhatti mentioned, the type 1 opt-out is confusing and difficult to access. It's a paper form. The national data opt-out is insufficient to prevent the sharing, might actually be misleading. And I have real concerns as a sort of cyber professional about pseudonymization as providing adequate safeguards. It's well known in the academic community that unless you anonymize and aggregate data, there's always a danger of re-identification if, for example, a bad actor got hold of the entire database. Fourthly, data protection impact assessment. It hasn't been published. We haven't seen it. We presume it's incomplete. Are GPs expected to do their own DPIA? Again, I mentioned they're responsible for compliance with the GDPR. So have they been provided with a template? No, they haven't. So this then leads you to the question of, well, actually, does the scheme comply with either the data protection principles or the Caldecott principles? Possibly not as it's currently structured. So this leads to certain risks, and not just the risk of a fine from the ICO. The ICO, we understand, is now engaging with NHS Digital to try and sort some of this out, but also the risk of litigation. And just to briefly mention that the government does have some form for disclosing data where it shouldn't. This is a case dealt with by my colleague Tamsin Allen, and it involved the publication of a spreadsheet of asylum seeker and refugee information in the public domain, which divulged details of individuals who had fled from regimes who had persecuted them. So that was a compensation claim. Potentially, we may see some litigation if it all goes wrong. Other potential concerns, the sharing by NHS Digital of potentially re-identifiable data. Going back to this question of why have they chosen pseudonymization? Why not anonymization, which was the care.data proposal? Why centralize the data as well? Centralization in a big database is vulnerable to threats from particularly sophisticated state-sponsored actors. And because that data is still re-identifiable in theory, that again poses a risk to all of us. Finally, the sharing of our data by NHS Digital with potentially commercial third parties, again by analogy with the DeepMind case, and we're not sure whether there's going to be any input, any fair value to us. And it's our data at the end of the day, and it's our NHS that we've built with our taxes. So what can I do if, if you are listening to this? Well, first of all, we're exploring the possibility of, we've skipped ahead, of a legal challenge with campaign groups, particularly if matters don't improve during this consultation period. So that's the first thing. Secondly, if you're a GP listening to this, well certainly you might want to consider exercising your accountability duties, although you've been directed to share this data. You are also a data controller, so scrutinize the scheme yourselves, ask the difficult questions. Do you have a DPIA? Do you have that data privacy notice? Do you have enough time to inform your patients? And finally, exercise the right to opt out if you're unhappy. Med Confidential has been stellar in publicizing information about the ability to opt out, and also actually processing opt-outs for people themselves if they wanted to. So I think I'm up to my time. Thank you very much, but I'm very open to questions.
Thank you so much for that really important overview of the legal considerations. I'd like to move on to our final speaker, Hassan Choudhury. So Hassan leads on digital health at Healthcare UK at the Department for International Trade, which is a DIT, with a global role advising DIT commercial teams in over 100 UK embassies. He co-founded Health IQ, an award-winning health analytics agency, holding Chief Information Officer and Chief Commercial Officer positions before its acquisition and his exit in 2019, apologies. He's now director at Vita Healthcare, strategy lead at the Source Group, a mentor for both the NHS Innovation Accelerator and Simulation for Digital Health, co-chair of the PM Society Diversity Interest Group, and holds an honorary research post at Imperial College London. Thank you for joining us today. Take it away.
Thank you so much, and a real pleasure to be here with you. Thank you so much for the invite. I'll just get my slides ready to show. Thank you all. So I've been asked to offer an industry and trade perspective I would like to start with a disclaimer that I speak today only for myself and do not represent any organization. I'd like to be head on with some of the issues that are raised. So importantly, none of this feels new. And I think that's been touched on by every single one of my fellow panelists. We've made this mistake before, and we keep endangering citizen and patient trust when it comes to a valuable resource of, as Osman clearly explained, not direct care. We're using this data for secondary use, for planning and research and other things. And in that area, we need to make sure that there is trust, and that's really been damaged more than once. A point I'd like to make, and it's been raised already about Gp Dpr and care.data. Now, while it is a similar issue in the sense that we could have done that better, and there was some communication, although it was poor, interestingly, that was NHS England and the precursor to NHS Digital, the HSCIC. This time round, it's just NHS Digital. And I've got to say, from wherever you sit in the landscape, NHS Digital is not the organization that you would expect to do comms across the entire country. They would be the ones that you trust to hold the data, but they are not the type to do the communications. So doing it by themselves was always going to be an issue. And in that sense, I do feel a little bit sorry for them. It's also been raised, Monika mentioned, the Royal Free and Google DeepMind, and how they were raked over the coals by the ICO. Now, what's interesting is one of the key findings of that particular sad incident is that they made a mistake in thinking that handing data over to Google DeepMind was part of direct care. So they mixed up direct care and secondary use. That isn't the issue here. In fact, the issue really, and I agree with Osman and how he and North East London CCG have pushed back, poor communication, not enough time, no consultation, to be honest, and putting the GPs at tremendous risk, actually, of what they would have to do as controllers. So there's no disagreement with me on it. But to say that NHS Digital are the bad guys in this, I do feel sorry for them, because when you think about what they've done, and this is an example from last July, when they were leading on a lot of COVID-19 programs, you'll see the work that they do, and it's good work. They are trying to be the best partners they can for the health and social care system for England, and making sure whatever they do is protecting the citizen and the patient. And they were the ones that began the Empower the Person program. I just feel that this particular issue hasn't been handled well, but that doesn't mean that NHS Digital themselves are an issue. Now, after care.data, we had tremendous success in gathering stakeholders, whether they were on the medical side, the academic side, or industry side, talking about how we can make sure we get the right messages out to maintain trust. So understanding patient data, led by the Welcome. And you'll see that they had lots of resources, and they really did argue, because we all know that there's value in making sure data is available for secondary use. And across Europe, data saves lives. So there were lots of different stakeholder initiatives. But during COVID, you'll see this. Now, I've put the link in the bottom right corner, the BMJ. This was the Cardiovascular Disease COVID UK initiative with the British Heart Foundation and NHS Digital. And you'll see that, and this is a complicated schematic, but in the middle of it, you'll see that there's a CVD COVID UK de-identified linked dataset within NHS Digital's trusted research environment, the TRE, which Osman mentioned. And you'll see that I've put in the top right corner the GDPPR. Now, the reason why I mentioned this, and there's lots of acronyms, is because we've been using pandemic planning and research. We've been using this data. This has already led to work within the trusted research environment. There are good things happening, and we need to make sure that continues. And you'll notice that this is talking about de-identified data. Now, what's the message been to industry? It's been repeatedly, and this is the tech vision from the Secretary of State, and you'll see the 4 guiding principles in the top right corner, privacy and security. This has been a consistent theme throughout. when we had the Code of Conduct for Data-Driven Health and Care Technology, and that was upgraded to the Guide to Good Practice. Again, that was a clear theme. We have the DTAC, the Digital Technology Assessment Criteria, led by NHS. Again, that's a clear theme. So the message from every part of this country is that we've got to treat data right, got to make sure citizens are aware of what's going on. Monika went through many of the principles. Those are the key messages. We also had the National Data Strategy, and you'll notice that I've put a quote out to the right-hand side that data is supposed to be in and data use seen as opportunities. Now, unfortunately, this has taken us back, despite all of our efforts to make sure that the tech industry and biopharma and others would see that we've got to use data the right way. This has affected trust, and this affects innovation, and this affects productivity in the country, and this is something that damages all of us. Now, I'd like to ask head on, why are we so cautious about industry? And by which I think we are most cautious around big pharma. Now, historically, and if you read Ben Goldacre and Bad Pharma and other things, you'll notice that pharma have over the years made many mistakes. But the current position in the UK is that you have drug companies who are going to apply bona fide research, and they're not going to get the kind of data they need to do that research. At that same time, we're going to hold them to a very high standard for health economics, for example, with NICE. And we're going to say, you must achieve this in order to get your innovation into the system. So we're raising the bar, but we're decreasing the ability, the capacity and the capability for them to be able to do the work. And I think in that sense, we end up losing out on innovation, and we're competing across the world. If another country, say Israel, is able to put fast track for lots of different drugs and therapies, then drug companies will go to Israel to do research on the outcomes of that drug, because that drug has been in use. And they won't bring it to a country where it's not been in use. And those are the kind of problems that you face. So we're in danger of giving mixed messages. At no point should the citizens' rights be affected at all. At no point should we lose out on the key elements that have been mentioned by all the previous speakers. But there is something where we need to find genuine partnership with industry. And that could be as simple as the trusted research environment, which is already in place, where data doesn't leave. And in fact, researchers come into environments where you can see what they do. And they have to be bona fide researchers, named and approved. And they have to have their research studies understood. And that has to go through assessment before they get access. And it's these environments that I think are the future. And I think that's what we're going to be telling the world about the UK story when it comes to data, because we do have a fantastic story. And we do often get asked by countries around the world for help on primary care, for help with digital primary care, and help with research in primary care. Brexit, I have to admit, Brexit has worried many investors when it comes to bringing their innovations to the UK. And that's something that will affect all of us in the end. And I think we need to consider how to keep the balance. Of course, the citizen is primary and their rights are primary, but it's possible for us to be very careful about what we do and gain on both sides. But we can't have our cake and eat it. We can't tell industry, you can't have access to this data. We don't trust you, we don't like you, but can we have your innovation? And can you meet our very high standards of regulation? That just doesn't work. So final thoughts, I agree with much of what's been said, but I think finding the balance is key. I applaud Osman in particular for his work in LCCG in promoting the specific things that were misunderstood about this, about how this could be viewed as a problem for GPs at a critical time when they're busy and they may not understand that they're going to be controllers and under risk. And I must say that when we push back on this particular issue, I don't have a problem. My concern is more general about partnership with industry. Thank you so much.
Thank you so much, Hassan. That was really useful. I'd like to invite all of the panelists to put their cameras on. Thank you. And Monika as well. Thank you. And then we can move into the question and answer session, if that's all right. We do have quite a few questions that have already come in, so I'll just take them from the top. I think some of the questions came in quite early on and may have already been answered, but I will mention them again. So the first question, does a lack of impact assessment and using identifiable data without patient consent breach the GDPR Act? So I think I should direct that to Monika, maybe, and then the rest of the panel can answer too. Thank you.
I will sort of tease that out. There's actually there's two issues there. This is a slight misunderstanding, but consent is not actually the legal basis here. It's compliance with legal obligation being the directions, and also for the sensitive data, there are certain public interest and public health conditions which are being relied on, not consent. The purpose of the opt-out is as a safeguard, as proportionality. I don't necessarily think that consent is the only basis. It could have been chosen as the basis by the government, and maybe it would have been arguably a better basis to proceed on. However, it's not necessary to rely on consent under GDPR, so I just thought I would point that out. On the DPIA, the consequence of that is that the opt-out is being offered, but it's not the same as a consent. DPIAs, well, yes, the DPIA is a legal obligation. We don't know if NHS Digital has carried out one and if they're going to publish it now, but certainly without a DPIA, that does raise questions about the legality of the scheme. Yes, that is a real issue.
Thank you. I can see that Hassan's got his hand up. Hassan, would you like to add your thoughts?
Thank you. I would defer to Monika on the legal issue. But the key is a point that Azeem made earlier, which is that if you have a data set and people opt out of it, and it's no longer representative because it no longer represents the population, then the data is less valuable. So they would never have gone with consent as their option. And they should have done consultation, absolutely. But we have a problem where there's lots of data collected, which is not going to be asked for consent. An example would be our cancer registries. And for the longest time, we've made sure that there's not an option for consent because of that argument, that as soon as some people with cancer pull out of it, then that damages it. So therefore, there is already a standing order, Section 251, in order for you to be able to get access to that data for the cancer registries. And that's what's happening. But that data doesn't go to industry. That data is used internally by Public Health England at the moment. So we have to be careful that sometimes these different bases are used for different reasons.
Thank you. Professor Majeed, would you like to respond?
Thanks. So I think the issue of consent is that if this system was opt-in, we'd find very poor compliance with the use of the system, and so the system would basically collapse because so few people would opt in. So as Monika said, it is covered by the law, and so it's an opt-out system rather than opt-in. And I think, as Hassan mentioned, if people did opt out, that would then damage the value of the data and its usefulness for the NHS and others.
Thank you. And Osman, I saw you nodding as Monika was speaking, so please show.
Yeah, so I agree. Actually, this is a legal direction that's been mandated, and I think much has been said already, but essentially the problem with me as a GP is that practices have been asked to do a data protection impact assessment to say what's going to happen with the data, but we don't know because NHS Digital haven't told us.
Thank you, and I can certainly agree with that as a general practitioner myself. Hassan, your hand is up again.
And very quickly to say that that's what seems really unfair for the GPs, and which is why I'm glad that the GPs push back. And North East London Clinical Commissioning Group and LCCG have done a sterling job of that. So well done, Osman.
Excellent, thank you. I'd like to move on to our next question now. So a question from one of our participants: with the current setup, would you feel comfortable about your data being shared, and would you choose to opt out? I'm not sure if it's a bit of a loaded question. You can not answer, you can decline to answer if you wish.
Yeah, I'm up to answer. So I've not opted out. My data will be used for research and planning, so I've remained in the system.
Thank you. Hassan?
I'm on the fence. Now, the reason why I'm on the fence is because I personally understand the value of research. I understand the value of what's happened. I'm not particularly happy about this one. And I think in that sense, I'd rather make a little bit of a protest. But if this was done correctly, if it was done with consultation, didn't put the GPs at risk with the DPIA and other things, then I would definitely leave myself in, because I've got no problems with going through NHS Digital, because I've seen how tough it is. And I think that Azeem and I would have better luck getting into Fort Knox than we would of getting data out of DARS sometimes. It's not easy. They do make it tough. They make you jump through hoops. You've got to make sure that you pinpoint exactly why you want the data, who you are, and even then you can get lots of feedback saying, well, maybe not. So that I'm not concerned about, but this particular one, maybe.
Thank you. And Osman, again, smiling.
Yep. So thanks. So as it currently stands, the way that it's currently set up, I've opted out, and because I don't believe that the current way that the system is set up is correct, and there should be differentiation between local use and national use as well. So there are lots of caveats, but as it currently stands, I'm not happy with how it is and have opted out.
Thank you for being so honest. And Monika, would you like to answer?
I have printed the opt-out forms and they're on my desk, and I am waiting to see what happens this summer, because there is still some time to potentially turn this scheme into a scheme which is better thought through. But for example, at the moment, as I said, I haven't seen the DPIA. I may see that and think, well, actually, this is a bad idea, and submit the opt-out forms. But yes, the time is ticking, isn't it? Because the 1st of September will come up on us very quickly, and the fundamental structure of the scheme, the government isn't, for example, proposing to change the centralisation or the pseudonymization, or I have not heard that yet. So yes, those are all relevant points in my consideration.
Thank you. Well, you have until the 25th of August to decide, so a little bit longer. Osman, would you like to jump in?
Yeah, just to also say that just because you opt out doesn't mean to say that's it. You've got the option to opt back in. So, you know, if the system changed and I was happy with it, I would exercise a right to opt back in. So it's not an all or nothing. You can exercise your right either way at any time.
Thank you. I'd like to move on to the next question. So what is the difference between Gp Dpr and general practice extraction service? Couldn't NHS Digital be sharing patient data already with third parties if they wanted to via the general practice extraction service?
Yeah, I can come in first on that. So the GPES, so the GP extraction service, is not that great. It is very clunky, and I can see why they want to change it. And I'm all up for that system being changed. The problem with the Gp Dpr, which is a program that's not going to overnight change GPES, but it's over 18 months, as I understand from what NHS Digital have said, it's a gradual process. And that the problem is that Gp Dpr takes out a lot more. So it takes out, you know, not just what conditions you have, but, you know, who you saw, when you saw them, why you saw them, what they coded, what they did with your data. So it's a lot more. And that's the issue. It's the quantity of data that's not proportional, and that's where GPES differs.
Thank you. Hassan.
So this is a difficult point to make. There's lots of data available at a very coded, granular level at secondary care. So Azeem mentioned hospital episode statistics. Now, for a long time, we haven't had that same national picture available for researchers in primary care without going to CPRD, the Clinical Practice Research Data Link. Now, what you find now with Gp Dpr is that you will have a data set that's even more powerful. It has a lot more fields, has a lot more data. So what I think's happened, and I'm guessing here, and I'm speaking as a private individual, is that I think NHS Digital saw what was possible in the pandemic, because it has seen really interesting things with pandemic planning. Open Safety and other things have shown the power of linked data sets for this planning. And I think they wanted to put it into a pot and then say, but don't worry, because we're trusted, don't worry about what comes out, we'll look after it. And the concern actually from many people, primary care specifically, so the BMA has argued, RCGP has argued, is that you put it into this pot, that's the problem. We're not so concerned about you being the pipe, the filter of what comes out of that pot. And NHS Digital is very strong at that point. We didn't want it in the pot in the first place. And I think that's where the conversation really is difficult for the layperson to get into. So GPES, completely agree with Osman that the GPES thing is clunky and it didn't give NHS Digital that richness of data. It's tried to improve that richness of data without asking, thinking, well, we've got GPES, what's the problem? And that's the thing, that's why I made in my presentation the point that NHS England aren't involved in this, and then everyone's asking NHS Digital what they're doing, and it feels like a bit of a category mistake. Asking NHS Digital to do comms isn't their strongest point.
Thank you. Is there anyone else who'd like to add any further thoughts? If not, I'll move on to the next question. The next question is, will opting out affect communication between hospital and doctor's surgery?
I'm up to answer that one. No, it doesn't affect your direct clinical care. So that will carry on as normal if you opt out. So doctors can share information with other doctors or other NHS staff for your direct clinical care, even if you don't take part in this system.
Thank you. I think that's quite straightforward. Thank you. So the next question. So NHS Digital have said that they will not sell our data, but says that they will charge for access to the data, basically meaning that they will sell it without making any profit. The questioner has asked for your opinions on this, and I'd just like to add that one of the thoughts that I'd heard was around the fact that they will charge for access, but will we, as the taxpayers or the people whose data is being used, will we be able to benefit from whatever is developed as a result of our data, or will those benefits be sold back to us at a cost to the taxpayer? Hassan, your hand's up first.
Thank you. And Monika made that point in her presentation, talking about what's the value coming back. So I think we need to make a distinction between research and when we're doing something that's not research. When it's research, and NHS Digital has got a data access research service, DARS, which is there for you to say, this is research. And in that sense, they're going to do their cost recovery. So there's not going to be money coming back to the public purse. The rest of us aren't going to benefit. This is about NHS Digital just washing its face, if you like. It's just making sure that it covers its costs. That's not where the money is. Where the money really is, and where we're really concerned as private citizens, is what happens to that whole data store. Is that going to get sold to the Americans, right? That's the concern that people have. But this particular issue with NHS Digital and DARS is about research, and it's just about NHS Digital covering its costs.
Thank you. Osman.
Yeah, so just to extend that, I think Hassan touched upon it as well in his talk around the use of data and how it is being used. And I think there was a mention of the COVID planning, and that's an example of where data has been used and extracted under national guidance. And actually there was a legal challenge for the government to actually publish what happened with that data. And it's clearly available. You can see that data was sold to Palantir, an organization that's not got the best record. And that data was sold to them for £1, only for the contract to be extended. And for a 4-month extension, Palantir basically paid 1 million. So there was money that changed hands. So I'll just leave that there. And it's open and transparent that information is available.
Thank you. Would anyone else like to add anything to this question?
Yes, I mean, I think it's fair to say that the focus at the moment has been very much, especially in my talk, on step one, which is the transfer from GPs to the central store. But then the question of what happens in terms of the dissemination and sharing of data from the central store is a separate and concerning issue. In the documents which have been published around the scheme, the purposes for sharing potentially are quite broad. And although they do sort of make clear that the data won't be shared for marketing or insurance purposes. Anything else is potentially fair game, including the sort of DeepMind analogy, which is sort of sharing with a commercial organization for the purposes of health improvement. I suppose the sort of question that you might want to ask yourself when you're thinking about the scheme as it currently is structured and whether you're happy for your data to go into it is if your data is used to create some sort of tool for Google or Palantir or Amazon, our NHS data is then used to create a tool which, okay, may be used in a hospital, but then they then resell it for enormous profit around the world, and they've been able to develop it basically using our data because our data store in the UK, our GP records are so fulsome, and there's a sort of unparalleled joined up system in the UK. Would you be happy with the idea that a little bit of you is part of that sort of commercial benefit to Google sold around the world? Some people would say, I don't care, Google can do whatever they want with my data, they already do. But other people, campaigners I've spoken to particularly, might genuinely say, actually, I'm not happy for my data to be used in that way. I never contemplated that my care records would be used to enrich Amazon or Google down the line. And for that reason, I'm opting out of this scheme.
Thank you. And I think it also feeds into what Osman said at the beginning about trust. So as GPs, our patients should feel free to say what they want, whether they're in abusive situations or anything about their sexual history, etc. And so I think for us as GPs, we most certainly have concerns that it will limit what patients will tell us, which may, in fact, impact their care. Hassan, I can see that your hand is up.
Thank you. I think we're getting to the heart of the matter here. Osman explained the difference in direct care and research planning, but here we're coming to a distinction in that second part, in the latter part. So if it's bona fide research, whether it's funded by pharma industries, whether it's funded by tech industries, if it's bona fide research, Imperial could be involved as an example. That's one category. There's another category, which I think Osman's point about Palantir is germane. What the hell's going on there? And who's doing it? And why is it happening? So I think we need to separate those two. When it's bona fide research, I don't think anyone has a disagreement with data, the appropriate amount of data being provided for bona fide research, done in the right way, with the right safeguards, right transparency. NHS Digital provides data for research through the DARS scheme. And it does so with a group called iGuard, making sure that they protect it. And it also has registers of data release, so you can see the transparency of who they're giving the data to. I think all of us should be concerned about things that are outside of that, and we need much more consultation and transparency around it. But for the category that I'm talking about and for which I'm arguing, that's where I think that the trust has been damaged repeatedly. Care.data is an example of that. What the ICO found at the Royal Free and Google DeepMind is an example of that. And again, we're finding that with Gp Dpr. That's where we have to protect ourselves, because if that trust goes and patients decide to withhold their data, then innovation suffers, research suffers, the UK suffers. And I think that's where I'd like to make my point firmly, not to in any point disagree with the other section that we're talking about with Palantir and other companies.
Thank you. And just for people who may not know, iGuard stands for the Independent Group Advising on the Release of Data. It is a body responsible for overseeing the release of information. As we've discussed, there are 7 current members, but there is no election to that. They are recruited from various backgrounds. If anyone else has any further thoughts, or I can move on. Okay, so the next question, how will this data link in with shared care records? Does anyone have any?
Yes, so the two are quite different. The shared care record is a summary of your medical record used by health professionals. So unless you opt out of that system, if you go to A&E or hospital outside your area, they can view your record, or at least summary of record for your direct clinical care. So it's different from this system, which is around planning and research. So the shared care record is much more limited, has main diagnoses, drugs, etc. that you're on, and so it's helpful if you don't say travel somewhere else and fall ill and need to seek medical help from the NHS, so your usual GP practice or hospital.
Thank you. Osman's got his hand up.
Yeah, just to expand on shared care records, lots of stuff being done around the shared care record, and certainly in our area, we're looking to have that available to patients. And right now, patients can have access to their medical record as a shared care record, or just as a independent GP record, just by requesting that from the GP through things like the NHS app, for example.
Thank you. If anyone else has anything to add, I can move on. No? So I think the next question is directed at Professor Majeed. So Professor Majeed, thank you for showing the different sources of data. Why do different parts of the NHS use different indices? For example, breast cancer screening does from PHE does not include the breakdown of ethnicity, but the HES may, depending on how good the trust is at using the HES.
So this depends on each data system. So each system will collect its own data for its own purposes. So HES does include data on ethnicity, or at least code for ethnicity, as does GP record. Other record systems will have that field. And this illustrates the value of data linkage, because if you can link across data sets in a confidential manner, you can then pull in data from other data sets to fill in gaps in your own data. So if your data set, for example, has information on ethnicity, that can be pulled in from a different data set, for example, to fill that gap. But it's largely because these systems were developed separately and not from one kind of common source, and therefore each one has got different fields, different items that are recorded, and that's a historical legacy of where they were developed.
Thank you. Osman.
Yeah, and just to expand on that, there's been some really interesting work done around looking at data and how it's coded in primary care, and lots of variability. And Open Safely did this through a trusted research environment, so a TRE, that is how it should be. And they came out with some really, really good research and results. And again, that's really open for anyone to have a look at. So it can be done, and we find out things like this in more detail.
Thank you. I'll move on to the next question. And I'm really glad that it's been asked, because it was something that people have spoken to me about privately. So the question is, how will consent be gained from patients or service users who don't have mental capacity to make decisions for themselves? How will their data be protected? And I'd like to expand that slightly with, to ask the question about vulnerable communities in general. So speaking for myself, I've worked with refugees and migrants, people who already have a bit of a mistrust in the system and are worried about data sharing. How can we protect our vulnerable patients? Thank you. Who'd like to answer? Osman?
So I can come in. So I think that there is an issue here, because we're not asking for people to give consent or not. This is about people knowing about it and then opting out. So if people don't know, and patients who are vulnerable often don't know, then their data will not be opted out. So it's up to those who basically have can advocate for them to support them in that decision. But otherwise, that is the problem. So all of their information is going to be transferred because there is no opt-out.
Thank you. As far as I'm aware, and please correct me if I'm wrong, the opt-out forms are not available in multiple languages. Is that correct? So
there's lots of different sources for it. So if you have a look on the NHS digital website, then it's just available in one language. And you're right, in most places it's just English.
Thank you, because I can see that can also be a barrier to people learning. Monika, you have your hand up.
Yes, I think actually this question nicely illustrates some of the issues about both the very short consultation period, the pressure on GPs to fulfill all of the transparency duties, and the lack of information which is accessible and in other languages. Certainly, I haven't seen a version of the opt-out form. It's not easily accessible. It's a paper opt-out form. It's not an electronic opt-out form. The comparison, in my mind, between actually the process for COVID vaccination, which I found very smooth. My partner is actually a teacher of English as a foreign language. He teaches a lot of new migrants to the UK, and they all report that actually the process for COVID vaccination was very accessible, they found, to them, whereas they've not heard of this sharing scheme at all. And that raises real questions again for the sort of public legitimacy and trust in this scheme.
Absolutely. Thank you for sharing your thoughts. Would anyone else like to add anything? Okay, that's fine. I'll move on. I'm going to direct the next question to Professor Majeed, if that's okay. So you've already touched upon this, I think, in your talk about reasons to not opt out. So if we could just re-emphasize the benefits of the system, it might be helpful for our participants.
Yeah, so I think as people have mentioned, the data has a lot of value for planning and research. If people opt out in large numbers, that makes the data less valuable because some groups may opt out in bigger numbers than others. So for example, if say it was people in one part of the country which opt out of one particular ethnic group, that would then make the data less valid in terms of its outcomes. And so if there's a higher dropout rate, it does really reduce the value of the data. And we are seeing a kind of modest dropout rate at the moment in my own practice. Not huge, but we are getting kind of steady stream of requests coming in from patients to opt out.
Thank you. Hassan, you have your hand up.
Yes, I think we need to remember that NHS Digital is providing data to the NHS organisations that are doing planning and research. So if the data flow is affected to NHS Digital, then it will be affected back to others. And NHS Digital has made that case with other data sets. Whether this particular data set has been advertised well, promoted well, consulted is a separate matter. But generally, that flow of data from NHS Digital comes back to the NHS so that they can continue planning. And it goes to academics, it goes to all sorts of people within the system that need to plan for the system. So I think we should always be looking, if possible, to provide data for research unless there's a compelling reason not to.
If I can start to that, I think there was a degree of arrogance in this scheme. I think because for the past year, people got data from the NHS for research and planning for COVID, they kind of assumed this would go through without any great issue. So I think there was, a lack of consultation and a level of arrogance that perhaps is now coming back to haunt NHS Digital.
Thank you. Osman.
Yeah, just to echo that, I think there's a great value in having this data for planning and research, and I think the need to do so is there, but it needs to be done properly, and that's why there should be flexibility of opting in and out as confidence wanes with the public.
Thank you for that. We still have quite a few questions. I hope you are able to hang on, if our panel could hang on for them if you're able to. So the next question I'm going to read out, which will cause more problems for a GP practice? 1, contract and legislation breach by not activating the data sharing link, which becomes law. Or 2, potential ICO breach for sharing data to a system which doesn't follow the GDPR principles as outlined.
Okay, so I can probably kick off really. So I think there's certainly 2 things here. If we take them separately, I think the practices have been mandated to actually click the button to enable the data sharing, but I think they have to do that in consideration of what's happening with that data, and we've been asked to do a DPIA. So as a GP practice, absolutely need to do a DPIA. But if I don't know what's going to happen with the data because NHS Digital haven't said, then potentially I'll be breaching GDPR. So there is no, if we go back to the Health and Social Care Act 2012, there is no specific mandate that can be action that can be taken against GP practices, even though it's a legal direction that by law they have to do it. So I think that there is that caveat, and certainly that's the initial approach that we had locally in my area, where our practices basically petitioned to not enable that on the principle that we don't know what's going to happen with the data, because of the fact that there is a potential breach of doing something in there, pressing that button to enable the data sharing and not knowing what's going to happen with it. So breach of GDPR principles there.
Thank you. Would Monika like to jump in and share some thoughts?
Yes, can I just say what an excellent question, and I think this is the nub of the issue that GPs are actually struggling with at the moment. I suppose from the data privacy perspective, I have mentioned that as a data controller, if you're asked to do something which you're concerned may be unlawful in certain respects, or may not respect the data of the data subjects in certain respects, I don't know the detail of the GP contract, but I guess the question for you is, would you be bound to do something which is potentially unlawful by your contract, that puts you in conflict with your contract? And this again highlights why GPs are put in an invidious position where, although the scheme has certain flaws, which we've explored on this talk, fixing them, I mean, it's not realistic to expect GPs individually to go ahead and fix these. This is going to require change and pressure from the National Data Guardian, the ICO, government to actually sit down and potentially rethink certain aspects of the scheme. So I think they are potentially, if they don't fix these aspects for GPs, they're storing up trouble for the future. Particularly, I've gone back to the risk of data litigation. Well, of course, if someone transfers your data in breach of GDPR, you have potentially a claim against them. The point here is that potentially the claim is actually against the GPs, and that is not something that anyone really wants to do. They don't want to go and sue their family doctor for something that actually the government's directed them to do. There is obviously other action that can be taken against the government, hence why we are currently considering with campaign groups a particular litigation challenge against the government.
Thank you.
If I can start to that, I think the way English law works, unless the case goes to court, no one quite knows how the law will actually work. You know, that's my understanding of the law. So in a case like this, unless it went to court and the judge ruled in a certain way, no one's quite sure how the law actually would play out. So I think, you know, as a concern for GPs, they may get caught up in this process, you know, with the government saying it's fine, it's all legal, a patient group saying it's not legal, it's going to court. And if the case went to court, no one quite knows how it would actually, you know, how that would turn out. With the Cardiovascular data program, one reason why it collapsed was there were some GPs who refused to follow the government's directive. And so when they were then threatened with legal action, they said, well, we'll see you in court. At which point the government suddenly scrapped the scheme, I think perhaps because they were concerned it went to court, the government could actually lose the case. So I think there are concerns, you know, amongst GPs that will get caught up in this process. And as Monika mentioned, you know, we're the ones who'll be liable if there was a breach of law in some way. But until there's a court case, you know, no one's entirely sure what would actually happen to a GP practice.
Thank you. Hassan, your hand is up.
Thanks. And this goes back to a point I made about NHS Digital, that I think this is wider than NHS Digital. They're a non-departmental public body. And we then have to look at the Department of Health Social Care, the Department for Digital, Culture, Media, Sport, DCMS, who've got responsibility for data. And this therefore needs the National Data Guardian, as Monika mentioned, the Information Commissioner's Office. There's so many other partners that need to be involved. And that's why the BMA and the Royal College of GPs and others are getting involved. This needs to be a wider conversation. The consultation period is not long enough. The extension's not long enough. And I think while we are all agreed in consensus that it's too much pressure on GPs to go through DPIAs and not know the result, and also have to inform all of their patient list, including the vulnerable ones, and also at the same time, NHS Digital can't solve the problem themselves. So I think this is an intractable problem, and somehow we need a bit more time to resolve it. And once we do, I think we can get to a trusted answer. The trusted answer has to be where data doesn't leave, that researchers come into environments where you know what's going on. And that's been mentioned a few times, trusted research environments.
Thank you. We have
Again, I just want to add one more thing. The government has gone to court in recent months and lost its case as found, you know, to act as unlawfully, for example, in issuing contracts around COVID-19 work. So I think it's not always clear when the government reassures you this is legal. You know, we can't be sure it's the case until it's actually gone to court and been tested, because the government has lost cases in recent months where they've claimed they're actually legally, but the court ruled they acted illegally.
Thank you. We have a few questions around the opt-out. So one participant is asking, saying that they have nothing to fear and nothing to hide. So is it really wrong to just stay in? I would suggest.
It's up to, I think that this is where we need to have that publicity campaign. So as an individual, you have the right to exercise the opt-out if you wish. If you feel that, you know, there isn't anything you're too concerned about and you're happy with the principles by which the data is being shared, absolutely. You know, you don't have to opt out. But if you're concerned, you should have that right. So you should be informed enough to exercise it if you wish.
Hassan.
There isn't much transparency about what happens when NHS Digital does approve your DARS request and give you data. And I think that makes it difficult for people to understand what's going to happen. So is the data anonymized? Is it pseudonymized? Is it lightly pseudonymized? You know, there's all sorts of different things that can come out of NHS Digital. And when it does, who's getting it? So is there an approval process? So NHS Digital does have a list of intermediaries that it trusts, and it has its track record of what it's done with them and how it audits them, physical audits, as well as other audits. And they all have to self-certify and go through other assessment criteria to prove that they know how to handle data. So there is rigor in the process, but as Monika's alluded to, there's always risk. You know, if you pull data into one place, there's an opportunity for people to, especially with cyber now, to attack it. So there are lots of reasons why the layperson wouldn't know exactly what's going on. There are too many things to consider. And therefore, I think it comes down to principles. If you feel you haven't been consulted, haven't had enough time to consider, then that might be a reason why you might want to opt out. If you trust your GP and your GP is holding out and thinking, well, I'm not sure, then that might also be a reason. But the key here is that you don't need to worry about an urgent and immediate risk. This isn't an immediate, this data, as soon as you forget to opt in or opt out, it's going to get sold immediately. That's not how it works. You do have time to consider the issues. And I don't think that there's that kind of risk that people are worried about, but I'd understand if people opted out.
Thank you. If certain demographics continue to opt out, what mitigation is there in place, if any, to ensure that services remain inclusive and effective for those patients?
So I think that's a really good question. I think this comes down to the fact that actually the opt-out process is just a mess, because in East London, for example, we'd really value the use of the data for usage locally, but there is no way currently to differentiate local use for research and planning to national use of research and planning. And I think that's something that, again, somebody needs to look at. And the trusted research environment may help support that. And so if we have a process through which everyone has the trust in the system, and we know that certain groups may feel more sidelined and may increase their opt-outs, it will have an impact on research and planning overall. And that's a risk, but we have to balance that risk against the bigger concern. If it was explained properly to people, and there was a good transparency, and there was an easy way to opt in and out, I don't think many people would opt out. I think the opt-out is, a lot of it is protest because of the way that it is actually set up at the moment.
Thank you, Hassan.
So this is a difficult point to explain. In many examples, when you ask for data on ethnicity, you're told that this could be an identifier, potential identifier. So often as a researcher, you don't get the ethnicity data that you need. And sometimes it is important for your study. And there are certain conditions that require you to have the ethnicity field for you to go to do your sample control. Now, the problem we have then is the emotive language of a data grab. There are lots of privacy campaigners saying, well, why did you want all of these data fields, such as ethnicity? And researchers are going to make the case, well, actually, we did need it. And the question that's been put to us, it actually has an impact on the value of that data set for research. And I think, unfortunately, a lot of the time, especially we saw with COVID vaccinations, you saw people of color, of BAME extraction, saying they didn't want to be vaccinated. And there's a feeling, I can't prove this, but there's a feeling that maybe people who are BAME are more likely to mistrust the government when it comes to these issues, and maybe perhaps more likely opt out. So the data set will be less valuable. For the first time, we're going to have this data set that has ethnicity in it, for example, and we won't be able to use it. So it does seem like a real shame. And again, goes back to trust, if only it had been done correctly.
Thank you so much. We have got so many questions, and I'm aware that we've run out of time for people asking. The recording will be shared on Facebook and YouTube. If you'd like to send some further questions, we can pass them on to the speakers. Please send your questions to info@britishimer.org. Unless the panelists are happy to continue,
No problems.
Is that okay? I'm very mindful of your time.
I have to go. I've got another seminar starting quite soon, which
Okay.
I'm speaking at also. I'll have to probably go
All
quite
right.
soon.
I may ask one or more. So there's one question that's quite interesting. So why are we advising typed 1 opt-out and not national data opt-out? I would be happy for the NHS to learn from my info, but not third parties or government friends over whom I have no control.
Yeah, so there's lots of confusion about this, and this again is why we need it explained properly. So as I try to differentiate between the two, a type 1 opt-out is basically for your GP practice to say this data is not going to leave the GP practice and go to NHS Digital, and that's quite a difficult process to do. A national data opt-out, which in comparison is quite easy to do, is basically for you to say to NHS Digital, do not share this data on for secondary use. Okay, both are valid, but the second national opt-out does not stop your data flowing from the GP practice into NHS Digital. The concern is that the national data opt-out is not strong enough, because if you look at the data that's been provided, most of it under legal challenge as well, 80% roughly of national data opt-outs have not been honoured. So even though you put in a national data opt-out, NHS Digital can turn around and say, I don't think that applies in this case through a legal mandate or whatever. So they can overturn a national data opt-out. Currently, you can't do that with a type 1 opt-out. That's why the type 1 opt-out is stronger.
Thank you. There's a question that I think is quite pertinent to a few of our attendees. So there's a question asking about opting out on behalf of a child or family member.
Well, a parent can opt out on behalf of a child because they're the legal guardian for that person. For a family member, it would depend on whether you're that person's guardian or not. So that person has, is an adult, then probably isn't the case. They'll need to opt out themselves.
Okay, thank you. Is data on the app My Medical Record shared to third party? I think I'm not familiar with the app myself.
So there are a multitude of apps out there, and as we all know, we often just tick the agree to the privacy policy without reading it. So unless you've read and know what they're going to do with the data, we don't know what they're going to do with the data. So again, it really comes down to knowing and trusting and being open.
Thank you so much. I'd like to thank the panel again for being so generous with their time and expertise and for holding on for a few extra minutes. Thank you for all the attendees who've attended. We've shared the feedback link in the chat, and we'd be grateful if you could complete it so we can plan future webinars. Thank you. Thank you for attending. If people would also like to review the webinar recording, it will be available on our Facebook and YouTube channels as well. Thank you very much for joining, and I'd like to close the session.